Hello, my name is Husain Borki and I am second medical student. What's your name?
Murtuza,
And can I know your age?
50 years.
Okay. So today we are going to do your abdominal examination, which will entail me to percuss, auscultate and palpate your abdomen area. So is it okay?
Okay.
Okay. Let's proceed.
Make the patient comfortable in the supine position with a pillow under the head. To expose the abdomen, place the drape or sheet at the level of symphysis pubis, then raise the gown to below the nipple line just above the xiphoid process. Now first observe the general appearance of the patient. Note especially the skin, including the temperature, color, scars, dilated veins, rashes or ecchymosis. Observe the counter of the abdomen and if possible also observe the peristalsis and pulsations. Warm your hands and stethoscope before examination. Place the diaphragm of your stethoscope gently on the abdomen. Listen for bowel sounds and note their frequency and character. Occasionally you may hear the prolonged gurgles of hyperperistalsis from stomach growling, called borborygmy. If the patient has hypertension, auscultate the epigastrium and in each upper quadrant for bruits. Auscultate over the liver and spleen for friction rub. Now auscultate for bruits over the aorta, the iliac arteries and the femoral arteries. Percussion helps you assess the amount and distribution of gas in the abdomen, viscera and masses that are solid or fluid filled and the size of the liver and spleen. Percuss the abdomen lightly in all four quadrants to determine the distribution of tympany and dullness. Tympany usually predominates because of gas in the GI tract, but scattered areas of dullness from fluid and feces are also common. Note any dull areas suggesting an underlying mass or enlarged organ. This observation will guide subsequent palpation.
Okay, now stay relaxed. I am going to palpate your abdomen. So if you feel any tenderness, inform me.
Keeping your hand and forearm on a horizontal plane with fingers together and flat on the abdominal wall, palpate the abdomen with a light gentle dipping motion. As you move your hand to different quadrants, raise it just off the skin. Gliding smoothly, palpate in all four quadrants. Identify any superficial organs or masses and any area of tenderness or increased resistance to palpation.
Now can you flex your knees and take deep breaths? Okay.
Now for deep palpation, use your palmar surface of fingers. Press down in all four quadrants. Identify any masses, note their location, size, shape, consistency, tenderness, pulsation and any mobility with respiration or pressure from the examining hand. Correlate your findings. Signs of peritonitis include a positive cuff test, guarding, rigidity, rebound tenderness, and percussion tenderness.
Now I am going to percuss your liver. So now I am going to mark a little on your abdomen. So is it okay?
Yes, it's okay.
Okay.
Now percuss the liver. Measure the vertical span of liver dullness in the right midclavicular line after carefully locating the midclavicular line to improve accurate measurement. Use a light to moderate percussion strike because a heavier strike can lead to underestimate of liver size. Starting at a level well below the umbilicus in the right lower quadrant, percuss upward towards the liver. Identify the lower border of dullness in the midclavicular line. Next, identify the upper border of liver dullness starting at the nipple line. Percuss downward in the midclavicular line until the lung resonance shifts to liver. Now, measure in centimeter the distance between your 2 points. Normally, the liver span is greater in man than in woman and in taller compared to shorter individual. If the liver seems enlarged, outline the lower edge by percussing medially and laterally. Normally, the liver size is 6 to 12 cm in right midclavicular line and 4 to 8 cm in midsternal line. Place your left hand behind the patient parallel to and supporting the right and 11th and 12th ribs and adjacent soft tissues. Remind the patient to relax on your hand. By pressing your left hand upward, the patient's liver may be felt more easily by your examining hand. Place your right hand on the patient's right abdomen, lateral to the rectus muscle, with your fingertips well below the lower border of the liver dullness. Starting the palpation too close to the right costal margin, risk missing the lower edge of an enlarged liver that extends into the right lower quadrant. Ask the patient to take a deep breath. Try to feel the liver edge as it slides down to meet your fingertips. When palpable, the normal liver edge is soft, sharp, and regular with a smooth surface. If you feel the edge, slightly lighten the pressure of your palpating hand so that the liver can slip under your finger pads and you can feel its anterior surface. Trace the liver edge both laterally and medially. Palpation to the rectus muscle is especially difficult. Describe the liver edge and measure its distance from the right costal margin in the midclavicular line.
Take deep breaths.
The hooking technique may be helpful, especially when the patient is obese. Stand to the right of the patient's chest. Place both hands side by side on the right abdomen below the border of liver dullness. Press in with your fingers and up towards the costal margin. Ask the patient to take a deep breath. Now, for assessing percussion tenderness of a non-palpable liver, place your left hand flat on the lower right rib cage and gently strike your hand with the ulnar surface of your right fist. Ask the patient to compare the sensation with that produced by a similar strike on the left side. With your left hand, reach over and around the patient to support and press forward the lower left rib cage and adjacent soft tissue. With your right hand below the left costal margin, press in towards the spleen. Begin palpation low enough so that you can detect an enlarged spleen. If your hand is too close to the costal margin, you will not be able to reach up under the rib cage. Ask the patient to take a deep breath. Try to feel the tip or edge of the spleen as it comes down to meet your fingertips. Note any tenderness, assess the splenic counter, and measure the distance between the spleen's lowest point and the left costal margin. Approximately 5% of normal adults have a palpable spleen tip. Repeat with the patients lying on the right side with legs somewhat flexed at the hips and knees. In this position, gravity may bring the spleen forward and to the right into a palpable location. Percussion may help you to detect splenomegaly, an enlarged spleen. Percuss the left lower anterior chest wall roughly from the border of cardiac dullness at the sixth rib to the anterior axillary line and down to the costal margin, an area termed top space. Note the lateral extent of the tympani. Percussion is moderately accurate in detecting splenomegaly. If tympani is prominent, especially laterally, splenomegaly is unlikely. Dullness of a normal spleen is usually masked by the dullness of other posterior tissue. Then ask the patient to take a deep breath and percuss again. When spleen size is normal, the percussion note usually remains tympanic. To capture the patient's right kidney, use your left hand to lift up from the back and your right hand to feel deep in the right upper quadrant. Lift trying to displace the kidney anteriorly. Place your hand gently in the right upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press your hand firmly and deeply into the right upper quadrant, just below the costal margin. Try to capture the kidney between your two hands. Ask the patient to breathe out and then to stop breathing briefly. Slowly release the pressure of your left hand, feeling at the same time for the kidney to slide back into the expiratory position. If the kidney is palpable, describe its size, counter, and any tenderness. Occasionally, a right kidney is more anterior and must be distinguished from the liver. Press firm and deep in the epigastrium, slightly to the left of the midline, and identify the aortic pulsation. Assess the width of the aorta by pressing deeply in the upper abdomen with one hand on each side of the aorta. A normal aorta is not more than 3 cm wide. Detection of pulsation is affected by abdominal girth and the diameter of the aorta.
Now can you please sit up?
While the patient sitting up, check for costovertebral angle tenderness while placing your ball of ulnar surface of your left hand on the costal surface on the back side of the patient and check for any tenderness. Test for shifting dullness. Percuss the border of tympani and dullness with the patient supine and then ask the patient to roll onto one side. Percuss and mark the borders again. In a person without ascites, the border between tympani and dullness usually stays relatively constant. Test for a fluid wave. Normally, this test is performed by two persons. Unfortunately, this sign is often negative until ascites is obvious, and it is sometimes becomes positive in people without ascites.
So we have completed our abdominal examination. Thank you, Murtuza. Now, after examination, properly record your findings.